We'll continue our scientific sessions, and my great pleasure to introduce next presenter is Dr. Rachel Phelan. Dr. Phelan is Associate Professor of Pediatrics at the Medical College of Wisconsin's Children's Hospital. She specialized in pediatric blood and marrow transplantation for malignant and non-malignant diseases. And she is an expert and has scientific and clinical interest in survivorship care following blood and marrow transplant. She's a scientific director of the CIBMTR Survivorship Working Committee, and Dr. Phelan received her MD at Northwestern University School of Medicine. Her training in pediatrics was at the University of Washington, Seattle Children's Hospital, and her fellowship was at the University of Minnesota. So, Dr. Phelan, thanks for coming. Please, I look forward to listening to you talk.
All right. Thank you so much for the introduction, and thank you so much for the invitation to this meeting. It's been really great to reconnect with old colleagues, to meet new colleagues, and also to connect with the Cowden family. I looked down at the clock and I was like, oh, it's 2:30 already. So I know we're running a little bit behind. I'll try not to speak too fast, but maybe we'll see if I can make up a little bit of time. So once again, really happy to be here and talk about something I'm very passionate about, which is BMT survivorship. These are my disclosures. And I think it can be helpful just to start off with a quick case. And this is an example of a not uncommon type of complex patient that we do see in our survivorship clinic at Children's Wisconsin. So this is a young adult male. He had a history of transplant 4 years prior for a hemoglobinopathy. He had actually moved several times since his initial transplant, so had been seen at multiple different transplant centers since that time, and eventually had transitioned care to our center. When we saw him and went through all the effort to get his prior medical records, we noted that he still had a pretty significant iron overload, and because of all of his transitions and moves, had not had any consistent phlebotomy to treat that. He also still remained on hydrocortisone supplementation, as well as different types of electrolyte supplementation, and those had been started in the acute post-transplant period when he had developed acute GVHD and nephrotoxicity. But because he had not been followed consistently, those had never been weaned off. He had noted a chronic pruritic skin rash that appeared to be potentially consistent with chronic graft-versus-host disease, had not yet been fully vaccinated, had a history of a seizure disorder, and had not yet connected with a primary neurologist or primary care provider. And he also had very limited resources for travel to the visits and the multiple visits that he needed to complete. So as we're going through this talk, and then we'll kind of regroup in the end about this patient, I want us all to think about how can we improve care for these patients? Again, this is just one example of a patient that we see in our survivorship program. So first, I'm going to give a little bit more background. I'm sure many of you know a lot of this information, but I think it kind of sets the stage for my talk. So how has transplant changed over time? So all of us who transplant patients, and have been doing it for a while, know that over the last few decades, we've seen significant improvements in supportive care, including infection identification, infectious prophylaxis, infectious treatment, and the same for graft-versus-host disease. We also have made significant improvements in HLA matching. We've expanded on the number of different indications for malignant and non-malignant transplant. We have better availability of alternative donors, and you can see the graphic on the right there shows how haploidentical donors have continued to increase significantly over time. And we also have better bridging and maintenance therapies to decrease the disease burden of our patients going into transplant, and then subsequently reduce the risk of relapse following transplant. This is another graphic from CIBMTR. Since I come from CIBMTR, you might see a lot of graphics from there. But this also demonstrates how over time, the number of auto and allo transplants have continued to increase. Some of you might wonder what that little blip up in auto transplants was in the 90s. And that was actually because at that time, they were doing auto transplants for breast cancer and then subsequently found out that it did not work. And so then the numbers went back down to the general curve. And then I think we all know why the numbers dipped a little bit in 2020, but since then, those have come back up again. Also, not only the total number of transplants have gone up over time, but as you can see, the number of transplants that we do for older and older patients continue to increase over time. So in 2020, 27% of all patients receiving allo transplants for malignant diseases in the US were over 65 years of age. So over a quarter of all patients that we were doing allo transplants on. And that's in comparison to 4% in 2005. You can also see that our trends in survival have continued to improve over the decades and over the periods of time here. So this is looking at survival of patients with AML, both pediatric and adult, between 2001 and 2019. And you can see steady improvement there and statistically significant improvements. And the same for patients who are receiving an auto transplant for multiple myeloma. So it's a pretty simple equation in the end. You have increasing numbers of transplants that are being performed, and you also have improved outcomes for these patients. And the result will be a growing population of transplant survivors. And this study that was published back in 2013 did an estimation for how many patients we thought in the year 2030 would be transplant survivors in the US alone. And that number is 500,000 patients. And as a pediatrician, I think it's also really important to note that of those 500,000 patients, 14% of them are expected to be survivors of childhood transplant. And the reason why we want to think about that a little bit separately as well is that when transplanted as a child, you have many years and hopefully decades of follow-up care and also multiple transitions of care that we need to deal with. So what are these patients at risk for after transplant? Well, a lot of different things, and the risk factors are very complex, and the risk factors start even before the transplant process begins. So pre-transplant patients are coming in with different comorbidities. Their primary diagnosis for transplant can result in different late complications. For instance, if they come in with a genetic disease that predisposes them to different long-term health or medical problems, their treatments prior to transplant, and then also during the transplant period, they are receiving different conditioning regimens, whether or not that includes total body irradiation or myeloablative conditioning. Patients also obviously develop acute complications during that time. Post-transplant, patients develop infections, they have ICU stays, obviously develop chronic and acute graft versus host disease. They have chronic medical issues that we continue to need to deal with. And then we also, very importantly, have to think about their social support network that allows us to be able to identify and treat those late complications. And then their demographics, including age, gender, genetics, and lifestyle concerns. So I put up this figure not because I expect you to be able to even read it, because even I can't read it on my screen, but I think it's a really good demonstration of what we have to think about for every individual patient when they come into our survivorship clinic. So a patient can have late effects that really impact every single organ system of their body. And as I mentioned, there's not only risk factors that develop pre-transplant, but also post-transplant. And we also have to take into consideration their lifestyle and how that may impact their comorbidities that they develop over time and how we're able to identify and treat them. So it's a very complex and individualized process. It's also really important for us to remember that some of these late effects take a really, really long time to develop. So we're happy when our patients continue to see us 1 year post-transplant, 2 years post-transplant, but some things may take a decade or more to show up in terms of a late complication from the therapy they received. So the graphic on the left is from a study that we conducted at CIBMTR, looking at over 6,000 two-year survivors of non-malignant transplant. The median follow-up time was 7.8 years, and we were looking at the development of subsequent neoplasms following transplant. And we found that those patients had a standardized incidence ratio of the development of SN that was 11-fold increased from the general population. And as you can see, while a number of the hematologic subsequent neoplasms developed in the first 5 years, when we look at other solid tumors as well as skin subsequent neoplasms, those can take a decade or more to show up in certain populations. And then the graphic on the right is from a study where they looked at over 5,000 5-year survivors of childhood cancer, and they were looking for the development of cardiomyopathy, and compared that development with those who received cardiotoxic treatment to those who did not. And you can see that curve really doesn't start to plateau until about 30 years after the patient actually received that cardiotoxic treatment. Some of these late effects can also be very difficult to diagnose. So one thing that can be really hard for us to discern, especially in our limited time that we have with patients, is whether or not a patient is experiencing pain. So this is a study of over 700 older survivors of allotransplant and compared their pain scales to their siblings. And they found a 2.6-fold increase in reporting of pain. And it was quite significant for those reporting non-minor life interfering pain. And they did find that the risk of reporting pain was increased with the development and continuation of chronic graft versus host disease, less education, and a lower income. So it's really important for us to also consider socioeconomic factors and how those impact our patients. And these different risks also require different monitoring. So whereas we may be able to use the Framingham risk score in patients who have not had a transplant, there was actually a study that showed that it was not as effective and not able to be used as it's used in patients who have not received a transplant. And same with some of our other screenings, such as what we recommend for colorectal cancer screening, breast cancer screening, et cetera. That all has to be modified for the specific patient. Another thing we have to consider for these patients, and that I mentioned a little bit earlier, is that there are multiple critical transition points in their care. So they're being cared for in active therapy, maybe by one team. Then they have the end of therapy and enter surveillance, generally by the same team. But at some point in time, ideally, a patient will transition to another team that specializes in survivorship or a chronic graft versus host disease program. And that surveillance continues. And at some point in time, and that may occur before the end of therapy, during surveillance period, or many years after entering survivorship program, a patient will reconnect with their primary care provider or an adult provider if they're a pediatric patient. So all of these transition inflection points also lead to an increased risk of loss to follow-up. So we've seen that continued long-term follow-up is critical for these patients, but a study was done that another CIBMTR study looking at the 10-year cumulative incidence of being lost to follow-up. And we saw that about a quarter of all pediatric patients at 10 years were lost to follow-up care. And 10 years is too soon. So we need to make sure that we're improving that. Other risk factors that we found were younger age, non-malignant disease, public or no insurance, and distance from transplant center. So again, highlighting some of those socioeconomic factors that also go into follow-up care in these transplant survivors. Return to work is another transition that we need to also consider in our patients. So in this study, they looked at over 1,300 young adult survivors of allogeneic transplant. And you can see in the graphic on the left, it's somewhat reassuring that the number of patients working full-time continue to increase year after year, going up to about the 3-year time point, 50% of patients were working full-time. But then the graphic on the right shows that 50% of patients who were working full-time pre-transplant were now unemployed or on disability at 1 year post-transplant. So how can we improve that transition back to work for our patients as well? Chronic graft versus host disease also has a significant impact on survivorship. We know that it's a risk factor for many different late effects and can involve multiple organ systems. The symptoms can range from mild to debilitating. Oftentimes, it can require complex medication schedules to treat. Sometimes patients are on prolonged immunosuppression and require very frequent doctor visits, and can also, multiple studies have shown that it's had an impact on quality of life and mental health. And again, it can be very difficult to diagnose if not at a transplant center that's keen to look for it. This is another study I just want to highlight that was recently published last year, where we looked at over 1,200 2-year survivors of childhood cancer or childhood transplant for malignancy. These transplants occurred between 2000 and 2010. And you can see the 10-year cumulative incidence of any late effect for patients who had chronic graft versus host disease was actually 43%. So almost half of all patients at 10 years did have a reportable late effect from their transplant. And that's in comparison to 32% with no chronic graft versus host disease. And then when you look specifically at non-malignant late effects, that is even more statistically significant, where those with chronic graft versus host disease had a report rate of 40.7% and those without 30.7%. Interestingly, the risk of subsequent neoplasm seemed to be the same whether or not this large cohort of patients had developed chronic graft versus host disease. But then upon further analysis, they did see that the rate of subsequent neoplasms correlated with administration of total body irradiation, which is another known risk factor for developing an SN. And it's not just late effects and, identifying and treating those long-term conditions that have come from undergoing a transplant, but it's also really important to think about mortality risk and long-term mortality risk with time from transplant. So we all know as patients who take care of transplant patients who have cancer is in the first few years post-transplant, that's really the time period where we worry most about relapse. And a lot of patients continue to succumb to their disease within that acute time frame. But then as you can see, the further a patient gets out from transplant, the less we actually worry about them having their cause of death being their disease, but more related to other conditions that they're dealing with following transplant. So we actually conducted a study. So this is under or in manuscript preparation right now. So hopefully it'll be submitted and published soon, where we compared late mortality between 2 eras. And those 2 eras were from 2000 to 2006 and 2007 to 2013. And these are survivors of pediatric, or these are patients who underwent pediatric and young adult transplant for acute leukemia. And as you can see from this Kaplan-Meier curve, all patients, their survival gradually declined in both groups. And at 5 and 7 years post-transplant, they had similar overall survival between the 2 cohorts. So we didn't really make any significant progress in the late mortality of patients between the year 2000 and 2013. So late mortality in these patients has not improved over time. So then our question was, what is driving this continued late mortality in these patients? So to further look at the effect of the treatment era, we then assess the effect of the treatment era on survival using a multivariate analysis and adjusting for significant patient and transplant factors. And as you can see in blue, there appears to be a lower rate of death up to 5 years post-transplant. However, at time points after 5 years, which you can see in green, patients in the more recent era continued to die at a similar pace to those seen in the even earlier time period of 2000 to 2006. And patients who were older and those with extensive chronic GVHD also had an increased risk of death. So looking further into post-transplant complications, we saw that the frequency of acute GVHD was similar between the two periods of 2000 to 2006 and 2007 to 2013, but chronic GVHD was much more common in the recent era, and notably extensive GVHD. And this could possibly be related to more PBSC use, unrelated donor use, and we also often saw it in the AYA population. So knowing that the survival was similar between the two eras, we looked at whether the causes of death were similar in the two eras as well. And as you can see, 580 patients who were transplanted from 2000 to 2006 died during that time frame, and 571 who were transplanted from 2007 to 2013. The primary cause of death continued to remain relapse of disease, but we did make some advance in the more recent area in the number of patients who were dying from relapse. But then we subsequently saw an increase in the percentage of patients who were dying from graft versus host disease. So this further demonstrates how important it is for us to be screening and treating graft versus host disease, and how important all of the work all of you guys are doing and sharing with us today is, not only in the acute period, but in the multiple years following transplant. So how can we optimize long-term care for these patients? So, I think I've really emphasized how complex the care can be, how some of these conditions can be difficult to diagnose and treat, and then also, all the different risk factors and changing of those risk factors over time. So thankfully, we have a number of different survivorship guidelines that can help us. The Children's Oncology Group has a survivorship guideline listed here that we use quite frequently as pediatricians. NMDP and Be the Match also publishes a long-term care guideline. And then there's also NCCN guidelines that can help us. Our last transplant-specific consensus guideline was published back in 2012, so now over a decade ago. And I'm sure many of us who take care of transplant survivors have referred back to this guideline. At that time, 7 international organizations endorsed the guideline and covered 11 different organ systems and gave us some guidance on what we should be following in these patients long-term. And spoiler alert, team effort, a new guideline is coming soon that a number of us in the room actually have been working on. And what we did is, because realizing that the guideline we were using before that was transplant specific was over a decade old, we wanted to make sure to update that. And we ended up involving 11 different organizations from all over the world. So it truly was an international effort. We also made sure to include patient advocates, because we know how much their voice is important when we're thinking about long-term follow-up care. And we are very close to getting this published. So we'll be excited to share this with you guys. And this is just an example of one of the tables that will be available to help guide clinicians in caring for these patients. And basically things are broken down essentially by organ system. This is just showing an example of renal and urinary complications that patients may develop. And what we do is we list the late complication under that system, what the potential risk factors are, and what we recommend in terms of screening and potentially prevention in routine patients, and then how that may differ in special patient populations. And as you can see highlighted in red, knowing that graft versus host disease plays a major role in some of these late effects, we wanted to make sure to highlight whether or not you should pay special attention to that potential complication if the patient has graft versus host disease. Another guideline that I think is really important that everybody knows about is there was also a return to work guideline published in 2022 and endorsed by ASTCT. And this is something that we all can also refer to at different time points in the patient's journey, and really highlights the way that we can support the patient in getting them to their ultimate goal, if that is going back to the workforce. And as you can see, and I think as has been highlighted by many talks today, this really is a multidisciplinary team effort of helping the patients to reach that goal. Another thing that has been emphasized through multiple organizations is the use of survivorship care plans. So that's really taking those guidelines that we just talked about and putting them into action. So how do we translate all of that for our patients? Right there on the right is just the example of what we give out to our patients in our survivorship clinic. It looks like a little credit card. On one side, we list the therapy that they received, and on the other side, we list what they may be at risk for and what we recommend in terms of screening and what frequency that screening should occur. But debate is still up for debate. What's the best format? What should be included in this? When do we give it to the patient? Who do we give it to? How can we make sure that the patient is using it most effectively? So there's a lot of research going into the use of survivorship care plans and how to optimize them. There was a recent INSPIRE trial that was conducted looking at an online cancer survivorship program. And there were some risk factors that were identified for not using their survivorship care plans. So that helps us in, targeting those populations and being able to find a different way to emphasize the importance of these care plans. And then another study was done looking at whether or not we actually are improving the knowledge and compliance of the guidelines for our patients by using these survivorship care plans. And the good thing is that the median adherence to recommendations was 75%. And however, they found that despite almost 100% of patients having insurance, 26% of them still reported concerns about all of the medical costs that would come from adhering to the care plan that we provided for them. So once again, we need to consider the socioeconomic status and the implications of survivorship care and why there may be lack of care in these patients as well. Again, multidisciplinary teams are critical in order to put those guidelines into action. With our survivorship program, this is just a small list of the people that we involve, and we're lucky to have all these people that are really dedicated to our program. One unique position that we have within our program that I think I just wanted to highlight is that of a community navigator. And she really helps to connect our patients with different providers within the community. After a patient has undergone a transplant, and especially if they've had complications, it oftentimes has been months and sometimes even years since they've seen their primary care provider. So oftentimes when they are seen in our survivorship program, they say, hey, can you help connect me with a primary care provider that is comfortable caring for patients like me that may not be that straightforward, who has time for me, and who can we utilize for that purpose? And she's actually developed a really comprehensive map of the state of Wisconsin and Upper Illinois, where we have identified a number of primary care providers that are willing to take care of our patients. And we also have expanded that to include dental providers as well as mental health providers. So it's really helped us to connect patients and families with those PCPs and other very important care providers. So how is care changing for survivors? So how are we making it better over time? So we all know that there are a number of different emerging therapies. So some of these maybe will decrease the late effects that we see in some of our patients who have undergone transplant the more traditional way. So we're all aware of chimeric antigen receptor T cells, bispecific T cell engagers, checkpoint inhibitors, gene therapy. These are all different things that are coming down the line and really may change the face of survivorship care with time. This is just, again, a graphic looking at the number of CAR T cell infusions that we've tracked over at the CIBMTR from 2016 to 2021. And as you can see, these numbers are not going down anytime soon. But the thing to remember is these are relatively new therapies. As I demonstrated earlier, sometimes late effects don't show up for decades. And so the late effects of these therapies really are to be determined. And it's critical that we continue to conduct late effects research in this population. We also have been using more and more technology to reach our patients and to intervene in their care. So there's a number of different internet-based cognitive therapy programs that can be given to patients, mobile apps and games to promote healthy eating and exercise. Texting reminders for follow-up care or medical advice is something that we use. I think that spirometry, that mobile spirometry was a really cool thing. And I've also seen studies looking at echocardiograms that a patient can have one done by actually holding it up to their carotid, which is pretty amazing. And I've seen smart t-shirts that can actually do an EKG when a patient is wearing it. So there's lots that's coming through in that way. And we've also talked a lot today about quality of life and how patients telling us how they feel is really and should be a major driver of what we decide should be prioritized for research and endpoints for those clinical trials that we're conducting. And so recognizing the importance of patient-reported outcomes, at the CIBMTR, we now have electronic patient-reported outcome collection, and the number of patients that we're collecting that data on has continued to increase over time. And patient-reported outcomes, our PROs, are now being routinely incorporated into many clinical trials for very important reasons. And then I also want to highlight a little bit the use of telemedicine. So telemedicine, now we're all super familiar with telemedicine, right? I'm sure we've all used it either for ourselves or for our patients. And that was really driven by the COVID pandemic. But how can we use that technology more and more now that we are all used to using it? And so at Children's Wisconsin, we've actually developed a telemedicine initiative, which is also, I think, a really cool, innovative program where there are a number of different pediatric hem-onc private practices across the state who don't have all of the survivorship education resources that we have at our program. And so we're partnering with those practices to use telemedicine to provide a comprehensive multidisciplinary care visit via telemedicine, where the patient is actually at their primary oncologist's office. And then they join a visit with us via Zoom. And we all kind of rotate out and provide a 20-minute education session. So there'll be myself or a nurse practitioner talking about their medical care and our recommendations, a dietitian, a psychologist, a fertility navigator, et cetera, so that we make sure that those patients are aware of their different risks moving forward. And we're really hoping that this can serve as a model for future subspecialty telehealth initiatives. And this is just kind of, I'm not going to go through this entire algorithm, but we have this whole setup of communication and back and forth with their primary oncologist as well as with the patient. We provide the survivorship care plan and go through that with the patient. And we're always available for consultation either with the patient or with the primary oncologist that's taking care of them. So in conclusion, I think we've all seen that patients undergoing transplant are at risk for several long-term complications, and that really is regardless of age, gender, or underlying diagnosis. Each patient's risk for complications is variable, and screening plans for that patient really has to be tailored individually. Chronic graft-versus-host disease is a major contributor to non-malignant late effect development and definitely has impacts on quality of life. And lifelong follow-up, ideally in conjunction with a primary care provider and transplant specialist, is really critical when we think about caring for these patients. We're all hopeful that new therapies, either for the patient's underlying condition or for chronic graft-versus-host disease that have come out over the years, will help to reduce the burden or maybe alter the risk profile of late effects. But we really need to make sure that we prioritize long-term studies of patients that are receiving these new therapies. So back to our case example of our young man who's, we have made some progress here in dealing with his complications that he presented with, but we were able to connect with a PCP. We were able to also come up with his care plan and go over that with him. Because of our community navigator and our social work team, we were able to set up transportation and rides and check in with him to make sure that his, different visits and things were actually accomplished. We worked with him to prioritize what was most important with him and how he was feeling. So assessing his quality of life and patient-reported outcomes. And we really provided that comprehensive care model to him. So obviously we're continuing to work with this patient, continuing to work with a number of different complex patients that come to our clinic. But I hope that you guys have learned and thought about different ways that we can really improve care for these patients moving forward. One other thing I just want to highlight is that I did do a quick PubMed search prior to our talk here, and this is extremely encouraging for what I do. And emphasizing the importance of late effects in this patient population. You can see when I typed in HCT and late effect and hit search from 1979 to 2014, there were only 109 publications during that time. But from 2014 to 2023, there has already been 285. So this is obviously an increasing area of interest and research that I'm excited to be a part of, and I hope I've triggered your interest as well. And I'm happy to take any questions, but I also want to put a plug in for the Resilient After Chronic GVHD meeting that we're having the day before Tandem starts. So if anybody's interested in joining, it's being put on by PTCTC, which is the Pediatric Transplantation and Cellular Therapy Consortium. And Dr. Rotz, who's in our audience, is one of the organizers. So any of us would be happy to talk to you more about attending that event. All right, and I know I talked a little fast to try to make up time, but please, if anybody has any questions, let me know.
Area.
Yeah.
From Wisconsin.
Ah, great.
And my daughter was treated at Freuder under Dr. Palmer.
Okay.
Yeah.
Great. Yeah.
I know David Margolis really well.
Oh, wonderful.
So
I work with him every day. Yeah.
That's awesome. Please tell him Jody said hi.
I will.
So I see that you said you had both primary doctors that are going to work with you and not gloss over, I hope, and
right.
dentists. Is that for Badger Care too?
Correct.
Awesome.
Yeah. Yeah. So when we identify who would be a good fit for them, we also take into consideration their insurance. So we make sure that the provider accepts their insurance before we connect the patient with that provider.
That dental area has been zero.
Oh, it's a challenge.
Yeah. Thank you. Hats off to you. That's wonderful.
Yeah. Thanks. Okay.
Guidelines that you send out to naive primary care physicians.
Yes.
Space.
Mm-hmm.
On how to manage care. I mean, those patients probably only have 1 year the whole course of their, career.
Right. Right. Yeah. Great question. And then you're right. And then they have 15 minutes to decide, right? So yeah, we definitely acknowledge that. So every time we see a patient, especially that first visit where they transition care to us, we send out a comprehensive letter that says like, okay, for the cardiology system, this is what you need to be worried about. This is when we would recommend that the patient get an echocardiogram, for example. The patient may be at risk for chronic graft versus host disease, does not currently have it, but this is something that should be monitored. So we make sure that that is communicated to the primary care provider. And we're actually working on developing a new template that kind of makes that a little bit less cumbersome of a letter and really just puts the highlights out there and also identifies who is responsible for that follow-up. So I think that's another hard thing to know, right? Should the transplant specialist be the one who's ordering the echo, or should the PCP be ordering it? So that's one thing that we actually worked with a group of PCPs locally to develop that letter to make sure that it was actually helpful to them. So yeah, that's of critical importance. I totally agree. Mm-hmm.
So I just, hey,
Yeah.
So I just wondering the later effect of the bone transportation,
Yeah.
stem cell transportation. So you see the cardiac involvement and also the CGHD. I just wondering in the CGHD, they have the lung CGHD and the skin CGHD and whatever GI CGHD. Do you see how many the cardiac involvement or effect is from the CGHD? They have like heart GVHD.
Oh, do they have heart, GVHD, that
Yeah,
sort
yeah,
of thing?
yeah.
Yeah, I mean, we because we don't do biopsies and things like that, I don't have a list of everything also, by organ system with GVHD. And I don't know if that's actually available, but I think that is would be a good data set to have so that people, when they are seeing a patient like in the community with a lung issue, right? What is the likelihood that it is GVHD versus something else? So I think I understand what you're saying. That would be nice to have. We should try to develop that.
This is what I'm
Mhm.
wondering.
Yeah.
So maybe mouse model will see something in the heart, maybe.
Right. What's the percentage or
Okay.
possibility?
Yeah. This is in the home.
Yeah.
Okay, thank you.
Thank you very much. Yeah, that's great. And I think we need to move on to the last presentation.